Pediatric advanced life support is an important concept to really get a good grasp on this because what we're trying to do is overly prepare for in a systematic fashion to treat these stressful and tragic situations and de stress the process of doing so. So, again, we really try to overemphasize a systematic approach in training so that when we do, unfortunately, respond to these very tragic events, that we have um, a systematic process to control our actions and our performance, the procedures, the things that we do to de stress this event. Now, this pyramid is in reverse. They basically are saying there's a lot more to do at the beginning of any resuscitation, and it's to for a pediatric case, and really this is almost for a newborn. But we're looking at this reverse triangle here, in doing what probably seems simple. So we're dry, warming in position. It's suction if the patient is not responding, and it seems like they're not vigorously coming about, and there's a lot of thick secretions and meconium in the airway. This stimulation is just with that dry and warming as we're rubbing it and drying the infant or neonate. That this type of stimulation is supposed to bring around the transition from in utero to now the delivery stage. And keep in mind that this positioning here, we may delay the cord clamping for at least a minute or so as we dry, warm, and stimulate. We're trying to really take off all that extra secretions and liquid that's on the neonate, and to get them wrapped up and swaddled really well and warmed up. We like them to be nice, warm, and pink. We place them usually onto mom, and we kind of keep them skin to skin contact to increase that body temperature. If this does not cause the immediate response that we want that baby to look pink. We want that baby to start having a more vigorous activity. We want to see that facial grimace or that strong cry. If that's not occurring, we want to try to provide some supplemental oxygen. We know that the pulse oximetry doesn't really respond initially, and that pulse oximetry should be placed on the right upper limb, so that's preductal. And we want to try to get away with as least oxygen as we can. We're going to titrate up from 21%. If this response is still inadequate and we're not getting that vigorous, strong cry, a lot of activity and motion with the extremities, we're not seeing the heart rate pick up from 100 and it's not bounding and in the 150s, 160s, then we're going to start to ventilate and provide that positive breaths for the chest to expand and the air to be exchanged with carbon dioxide. If this does not bring up the heart rate and the heart rate is less than 60, we will then begin chest compressions. And this is where I need you to understand that there is that window. Well, it's under 100 and it's just above 60. So let's say it's 78 or 79 or even 69 or 62. You're going to have to make the decision. Does this child look like it's progressing? Does this neonate look like it's progressing and trending up towards that 100 and above the 100 heart rate with the minimum interventions that you've started? Or do you need to start with the chest compressions? Once the chest compressions have been initiated, look to get either IV access, IO access, or intubation, in which we can then administer your epinephrine 0.1 0.01 milligrams per kilogram. As we go into your advanced skills, we want to do things with a length-based tape. Here is a type of um, color scheme and color schematic that shows us for our length base, and the length base tapes are pretty much all same color coded. Doesn't matter what system we're using. They are all color coded to the same uh, length base, and some are weight based. And now all our drugs in administering will be weight based. And there you can see in this gray area is 3, 4, 5 kilos. And you're looking at usually as it comes down, we're looking at the jugs and the tube sizes and the fluid boluses as it goes on. So we want to use a length-based tape when we do so, when we do these resuscitations. All right, let's go over now just the BLS healthcare provider. When you get there and the baby has been delivered or the child is laying on the floor in the bed, wherever you find them, initial scene safety, we want to check for responsiveness. We want to get more rescuers to assist us in the resuscitation. You as an ALS provider needs to start thinking further downstream, looking for the the rhythm recognition, following algorithms based on the rhythm recognition. You want to also make sure that you get some kind of IV/IO access and some type of advanced airway where you secure an ET tube. Initially, your chest compressions will be 30 and 2. Then when you get the two compressions, that is compressors or two rescuers, that we're doing 50 to do. And looking at the rhythms, whether they're shockable or non-shockable. Our shockable rhythms are ventricular tachycardia and ventricular fibrillation. All other rhythms are non-shockable, do not shock, PEA. And that would be any rhythm that is not ventricular tachycardia or ventricular fibrillation. It would be any other rhythm that you can see some type of electrical or stimulation that is occurring, but it's not generating a pulse. The last rhythm is a rhythm that's called asystole. We'll continue to do 2 minutes of CPR, exchanging our providers so that we get good CPR compression rate and depth with our following the algorithm. Here we have the bradycardic patients in bradycardia. You come on and initiate the same thing, scene safety, identify other resources, and you're calling for additional help and providers to assist you with the ALS resuscitation of a pediatric bradycardic patient. Usually, bradycardia is due to hypo uh, ventilation or an hypoxia, or it could be some excessive vagal stimulation. And we're looking for, sinus Brady that's down below in the below 50 or around in the 50 below 60, excuse me. But basically, when you first walk in, it's the O2 IV and EKG that you put on so that you can see what's going on. You may want to place a 12 lead EKG to get better grasp of what's happening on the electrical side of the heart, but don't don't pause or don't take too much time to apply all of these. Go ahead and take a look and see if there is hypotension, altered mental status, and if there is, then we want to continue on and decide, what are we going to do here? We're going to start some compressions if the heart rate's less than 60 and they look bad here. Hypotension, altered mental status, mottled skin, delayed capillary refill, poor ventilations, all of these, are parts of the signs of shock. If bradycardia persists, then we're looking at initiating that IV or IO or ET tube in which you can give these drugs. Now, you're going to have to double doses if you're going down the ET tube, and that's not our primary site. The primary site would like to be IV or IO. And we can look over here in our box 0.01 milligrams per kilogram. 1 to 10,000, this is your preload. You can also give that via the ET tube. zero point 0.1 of the high dose epinephrine and the ampule. You double the amount if you're giving atropine. You know, your epinephrine dose and atropine dose, zero point 0.1. So if it's a 10 kilogram kid, you're giving 1 cc. Here in atropine, if it's a 10 kilogram kid, you're giving 1 cc here. And for atropine, you'd probably be giving the 2 cc's. Now, the only thing about atropine is that there is a maximum dose, so zero point 0.5 maxes out already, and there's a minimum dose of zero point 0.1 milligrams. So zero point 0.1, zero point 0.1, if you need to give more than zero point 0.1 so that you don't cause that reflex in the bradycardia from the parasympathetic side, recognizing that there's some blockade and it's going to try to resist that. So you want to give slightly higher than our zero point 0.1 milligram dose. Again, just to recap and go down this algorithm, get your O2 IV EKG, identify, if the patient looks sick and it's is in critical hypotension, altered mental status, mottled skin, poor activity, could go on with the chest compressions. If bradycardia persists, we need to get the IV access. We need to get that IO access as you started that here and initiated that all at the top. And then you're looking at giving epinephrine primarily, unless you're looking at some type of AV block or stimulation, vagal stimulation. We can go with the atropine. You can consider transcutaneous pacing, right? And think about the underlying cause. If our patient is bradycardic, but doesn't look extremely altered or sick and no real signs of hypotension. And hypotension, again, 70 plus, 2 times the age in years. So, you know, use that as a early marker. But then we're just going to observe and monitor and try to probably give more oxygen and try to ventilate more, as this may bump up the heart rate. And that's what we want to get, the increase in heart rate. But again, this patient on this side is what we're deeming as stable. The pediatric tachycardia with a pulse, we're looking at giving the patient the same thing. We're coming in, getting an O2 IV EKG, maintaining that airway, getting your IV, getting your IO, putting on your 12 lead, but don't delay that. But if we need that expert consultation, we're going to have to get that 12 lead. Then we branch out. Is it a narrow complex or is it a wide complex? They're using 0.09 seconds here. So it's, it doesn't have to be super wide, but when it is wide, it's very obvious. If it's narrow, it's probably going to be some kind of PSVT or SVT. It could be sinus tachycardia, though, where initially we may want to think about hypotension. As a result, with tachycardia as hypovolemia, fever, pain, anxiety. We want to look at something else that might be causing this as a sinus tachycardia, as a search for that cause and treat that cause, versus going into your SVT algorithm. And here they're telling you, our infants, we're looking at rates above 220 because pediatric TAC can go up to about 200. And this is when they're crying and irritable or they're dehydrated and volume depleted. And so in this case, when we're looking at SVT, they're saying that 180 could also be an atrial flutter at that 1-to-1 conduction. So this is our low range here, but remember that 180 could be a sinus tachycardia, and let's search for those causes. It's going to be difficult. Oh, excuse me. It's going to be difficult to get the child to have to do vagal maneuvers. So we can try to administer by trying to bear down. You can sometimes, when we put it in OPA, this causes a vagal stimulation. If you put in a rectal tempometer, this will cause some vagal stimulation. Um, then they may say put some ice over the eyes and carotid sinus massage. But these vagal maneuvers, if you can get some going, try to get them going. But if the patient is unstable, or I'm kind of consider getting that IV access, and adenosine is the drug that we would go. And we're looking at zero point 0.1 milligrams up to a max of 6, which is the adult's dose. And then we'll double that 0.2 milligrams with the second dose maximum would be 12 milligrams. Again, that's the adult max dose. And you could consider maybe a third dose. So we're following your PALS algorithm. At any time, you can definitely jump on that Medicom or radio to communicate online with base station physician or receiving facility as to what to do. Don't forget to go ahead, if you had the opportunity and time initially, to get your 12 lead, transmit that ahead so that they can also then advise you as to what's the next best step to do. If it's a Y complex now, step away for a while, take a step back. If it's a Y complex, if it's ventricular tachycardia, consider how stable or unstable this patient is. If we don't have these signs here, then consider, is this not as wide as we initially thought and it's maybe an SVT and requires something else? Adenosine? Um, do we need to give, other than adenosine, should we give, if it's ventricular in nature, do we consider antidepressant called amiodarone? And instead of giving that 150 over, that 10 minutes, we're going to give 5 milligrams per kilogram over your time period here, 20 to 60 minutes, so over an hour. If the patient is critical, and we have this hypotension, you have a patient that's altered, mottled skin signs, poor activity, poor tracking, poor following of any type of commands, no whimpering when you initiate the IV. You're going to go into synchronized cardioversion. And we begin with 1, say they give you a range of zero point 0.5 to 1 joules, and then we'll increase this to 2 joules per kilo. I think we continue this up to 10 joules per kilogram, and that's pretty much our max as we get up there. So you're going to continue to increase as you go up, and we can consider sedation. In the pediatric cardiac arrest algorithm now, if they've gone from that stable, slightly unstable ventricular tachycardia or monomorphic wide complex, and they deteriorated into a pulseless ventricular tachycardia or ventricular fibrillation, which will generate no pulse. Begin the CPR immediately, and once you see this change, or once you find this, if the patient becomes unconscious in front of you, you need to go directly to a shock. All right, directly to a shock. Now, if CPR has already been started, then we'll continue our CPR for 2 minutes. Then identify whether our rhythm is shockable, and then go ahead and deliver that first joule setting. And so we change from that zero point 0.5 to 1 joule and increasing, doubling that joule up to 10 joules per kilo. We're going to start off here at 2 joules straight off now. 2 joules per kilogram, and subsequent ones will double at 4, and then we'll continue to go up to a maximum of 10 joules per kilo. But it's going to be shock, CPR, identify, get our medication on board. 2 minutes of CPR, deliver the next shock, and 2 minutes later, deliver another shock. So we are working within a 2 minutes shock, drug shock regime here when the rhythm is in a shockable rhythm. The medications that we would give in between each shock, every 3 to 5 minutes would be an epinephrine. Every opposite of that would be amiodarone or lidocaine, and we'd give drug shock method. Again, your amio dose would be 5 milligrams per kilogram, and you may repeat that. Lidocaine, 1 milligram per kilo. We're giving that once we finish with the amiodarone. If we step aside and we go from a non-shockable rhythm, shockable rhythm to a non-shockable rhythm, this again is asystole, and we do not shock PEA. This means that any kind of electrical rhythm that we are seeing on the monitor that does not generate a pulse, and it's not ventricular in origin, it's not ventricular fibrillation or ventricular tachycardia, it could be an idioventricular, It could be an accelerated idiom, it could be a junctional, it could be sinus, it could be atrial fib. Any rhythm that's not VF or VT, we do not shock. You'll continue with your CPR. Basically, we're giving just epinephrine every 3 to 5 minutes. And you can look to see if they're shockable. If they go into a ventricular fibrillation of ventricular tachycardia, you follow this sequence. If they go out of it, you go back to this asystole or PA algorithm by just giving epinephrine. We got to consider possible reversible causes. So we already have an IV or IO. Let's go ahead and give your 10 cc's per kilogram of fluid. Let's make sure that you have a tube and that you're ventilating, that you have the capnography on. Consider that there is some acidosis going on. You can actually reverse this with giving some bicarbonate, follow the local protocols. Check out blood sugar to make sure it's not hypoglycemia. Consider the hyper or hyperkalemia. Check a temperature to see if they're hypothermic because pediatric patients don't really respond well when they're cold and that they don't have adequate sugar. Look for the tension pneumothorax after you intubate. Listen to your lung sounds. Make sure your tube hasn't migrated. Cardiac tamponade would show you jugular vein distension. You won't be able to hear the muffled heart sounds. You won't be seeing the narrowing on the pulse pressure, but you might be able to see some very narrow complexes or electrical alternans. And this would be across all leads on the 12 lead. Think about toxins, and then we have the clots and the thrombosis in the pulmonary circuit or pulmonary embolism or coronary occlusion in MI, and not normally seen a lot in our early pediatric settings. Keep in mind now when we're dealing with the pediatric that's in shock, early sign, it could be fever, hypothermia, they'd have some tachycardia. This is where we want to get the IVs and start to consider that 10 cc per kilo bolus. We can increase that as they move towards this middle. You're going to now notice that when you see delayed capillary flow, poor perfusion, they are altered, decreased urine out because the kidneys are not getting enough blood volume there. Um, it's very close. This is a very close sign here to becoming late, and then they start to crash and become altered. Hypotension ensues, and we're behind our curve in 8 ball. Let's just go back to review. So, any case that we're dealing with a pediatric patient that goes into cardiac arrest, recruit more personnel, apply the EKG or AED, determine that rhythm is shockable or not. You may want to start thinking about your ALS interventions so that as you have the CPR being done, you are going to start an IV, IO, and intubate. You're going to follow the rhythms on the EKG to determine what algorithm you'll be following. Your first drug of choice in either rhythm in the cardiac arrest state is going to be epinephrine. And if it is a shockable rhythm, your next drugs of choice would be amiodarone at 5 milligrams per kilogram or lidocaine at 1 milligram per kilogram with a drug shock sequence at every 2 minutes. If they're in a non-shockable rhythm, this again is a systole or PEA. We do not shock these rhythms. Your drug of choice, they're in this side, it would be epinephrine. At any time, if they go back into a shockable rhythm, ventricular tachycardia, ventricular fibrillation, go ahead and use your drug shock algorithm. In the case where the patient is bradycardia, there be many causes of bradycardia. The most prominent cause is the hypoventilation, hypoxia. It can also be excessive vagal stimulation by placing in an OPA or placing a rectal temperature in the rectum. This may cause a vagal tone that causes the patient to become bradycardic. If they are not compromised and they seem to be stable, look and observe for those things. Again, we're going to deploy O2 IV EKG, IO if your protocol allows you with poor IV access. After 2 attempts, you may initiate an IO. Consider it, but consider, taking the time to find these IV access and consider reversible causes. Consult your experts by jumping on the Medicom or communicate early. If the patient is unstable and is altered, hypotension, mottled skin, just poor activity, poor tracking, eyes closed. If the heart rate is less than 60, we're going to go ahead and start our CPR chest compressions, keeping in mind that 60, between 60 and above. So if it's like, you know, 70, you need to start anticipating that we may end up having to look at this route or consider, hey, if we're not going to do the chest compression, can we start medications to increase our heart rate? And it just hasn't hit that 60 rate where we are supposed to do chest compressions. And the best method is then circling thumbs technique for, your infants. Bradycardia now, once you get that IVIO, look at epinephrine or atropine. Again, you're gonna give your 0.01 milligrams for epinephrine, and atropine. Hey, it's just double that amount as far as when you did volume wise, because it's gonna be 0.02 milligrams per kilogram. And atropine is usually given for that vagal tone where you have excessive vagal tone going on, but consider the other causes. Narrow complex or wide complex tachycardia. If it's at that 180, think about that sinus tachycardia. I mean, children when they're irritable, they're fever, pain, agitation, they'll jump in heart rate. So consider that, is this actually an SVT, or is this a compensatory rhythm from the sympathetic nervous system? So look for causes, because we can treat that by bringing the fever down, by cooling them. We can comfort them by giving them maybe some type of pain medication or a binky, or something that they can be consolable. Look at fluid status. We can give them 10 cc per kilo of fluid and see how they respond to that. Now, if this is a possible SVT type of case and it is higher rates and they're not breaking, these when they're in an SVT, you don't see complex to complex deviation in its length between complex to complex. You'll see slight changes. In fact, the rate will bounce around if it's more of this type of tachycardia, sinus tachycardia, whereas in an SVT, it is dead on. There's no deviance between complex to complex, really, and we can consider your adenosine to convert that. Or if they're really unstable, then we want to look at synchronized cardioversion. Your adenosine dose, again, you can give that 0.1 milligrams per kilogram, and you can then go ahead and double that 0.2 milligrams. Max dose first time is 6 milligrams. Max dose second time is 12 milligrams. Synchronized cardioversion, we can start pretty low. Rather than going in at 2 to 4 joules per kilo, we start off 0.5 to 1 joule. We increase that up uh, incrementally, and again, 10 kilograms, 10 joules per kilogram would be our probably max. And you're looking at a wide complex, and it's possible ventricular tachycardia. If they are unstable, go directly to synchronized cardioversion. And if they aren't, then we can consider, is this really that wide, or should we give adenosine? And if it is, if you know that it's probably ventricular in its etiology, then go ahead with your amiodarone, 5 milligrams per kilogram over the hour or so. Run that in. We're probably going to have to put this in your 100 cc bag or in a buretrol, in which way you can control that administration over that hour. Lastly, when we go into the pediatric cardiac arrest, if they're in a shockable rhythm, it's going to be a shock, 2-minute CPR, shock, 2-minute CPR. And within these, we are also trying to give our medication. So we're going to first line drug would be epinephrine. Your second drug that you would give would be your antidysrhythmic. Again, in between that 2-minute CPR, shock, med, 2-minute CPR, shock, next med. If they go out of the rhythm and they're into asystole or PA, we do not shock the rhythm. So at the time that you charge up, you look, and they're no longer in that shockable rhythm, please dump the shock, follow your asystole or PA algorithm, and then we'd continue with CPR and give epinephrine with no shocks in the asystole and PAA algorithm. Now, if they then stop at the 2 minutes and you identify that they're in a shockable rhythm, please float back into the shockable ventricular tachycardia, ventricular fibrillation algorithm. by initiating and delivering that shock and defibrillation. Now we start off when you see this occur, you start directly at that 2 joules per kilogram, and then we subsequently increase to 4, and we can increase that up to 10 joules per kilo. Consider as we continue to run through the cardiac arrest algorithm the possible causes so that we can treat those.